A very pleasant good afternoon to all of our viewers and welcome to Let's Talk. We are so delighted that you have chosen to join us for this fourth in the series on cancer and the Christian. For the last 4 weeks,
The
we have
series
been
on
discussing
cancer and the Christian.
various elements of cancer. Our guest, Dr. Natalie Greaves, has been with us, and I do want to, right at the onset, take the moment just to, for those of you who may be joining us for the first time, just to let you know again who our guest is. Dr. Natalie Greaves is a lecturer in public health and coordinator of the MPhil and the PhD program in public health and epidemiology at the University of the West Indies, Cave Hill, Barbados. She also coordinates the social and preventative medicine clerkship and health and the environment courses in the MBBS curriculum and the primary health care and qualitative research courses in the Masters in Public Health program. She's, of course, as I said, uh, a lecturer there. She has a PhD in primary healthcare management with a focus on palliative day care from Warwickshire Medical School in the UK. She has completed National Cancer Institute's curriculum on cancer prevention and control. And most recently in 2019, she completed the palliative care education and practice course at the Center for Palliative Care, Harvard Medical School. There's so much more that I can say about Dr. Greaves, but we wouldn't take all of our time in introduction. We are delighted to have her with us in this final series. So, Dr. Graves, it's a delight to have you back
Thank you.
on Let's Talk. I know that you had quite a busy day,
Yes.
so we just want to say welcome.
Thank you, Dr. Greene, and thank you for this opportunity to share across the region. I know you have quite a big platform, so between the YouTube channels and the radio broadcasts and stuff, I have looked at the metrics and I can see that people are listening. So this is just a tremendous opportunity to have persons in the region and beyond, understand about cancer. So thanks for the opportunity to share. Yeah.
Yes, certainly, certainly. It really was a delight to be, to have been given the opportunity and privilege to talk with you over the past 3 weeks and this week making week 4. So we have shared a lot on cancer.
Mm.
You have uh, educated me in several areas, and I'm grateful for that. So over the last 4 weeks, we have discussed various aspects of cancer. But before we wrap up today, we want to pause just for a word of prayer. So those of you who are listening via Second Advent Radio and those of you who are watching on our various YouTube channels, we invite you at this moment just to pause for a word of prayer. Eternal Father and our God, be with us as we go into today's broadcast. We pray for your guidance and your Holy Spirit's presence. We ask that you will be with Dr. Graves. She has shared marvelously for the past 3 weeks, and now today she shares again. Be with her, give her wisdom, and grant that the information will, as has been in the past, will prove meaningful. Take full control and have your own way. In Jesus' name, amen. Well, Dr. Graves, um, I started saying that you have discussed various aspects of cancer, what causes it, the terminologies we have spoken about. We have even looked at specific kinds of cancer. I want us to spend some time talking about treatment options today. That's a concern because, cancer is so popular. So many persons are getting affected by this quote unquote deadly disease. Um, you have mentioned a few of these terminologies in the past, but can you just elaborate a little bit more? We're talking about treatment options, so we have various ones, and I'm just going to ask you to highlight the ones that you want to bring to the fore and just share a bit. If I am infected with cancer, what are the options available to me?
Okay. All right. So firstly, um, there's kind of like a mantra, like a statement that you can say. And the statement that you can probably help yourself to understand how a cancer should be treated is that treatment depends on stage. So last week we talked about what a stage is, and the stage is the extent of spread of cancer. It depends on the size and also if it's affecting nearby lymph nodes and things that are far away. So depending on the stage of the cancer, the type of the cancer, the fundamental diagnosis, that determines what needs to be done. Yeah. So there are some cells, when you look at them underneath the microscope, some cancer cells, they look very cooperative. They look like they got an instruction to change, or they were exposed to something and they became, as we were saying, bad behaved, and they don't want to be controlled. But they look like just with a small amount of discipline, they could disappear and get in line. And there's some, when you look at them under the microscope, they don't look well behaved at all. And you would know, as a pastor, as anybody, we are talking to persons in families and all walks of life, we would know that different things demand different treatments depending on what you're trying to achieve. So if you're looking at a cancer cell and it looks like it's very bad behaved, and it looks like it has the potential to spread and spread quickly and aggressively, then treatments tend to be matched to suit. And those tend to be perhaps more prolonged, what we call more aggressive and stronger treatments. So let's just talk about what those treatments are firstly. So one of the first days of cancer treatments, with the caveat that treatment depends on stage, is if you can see it and you can remove it easily and quickly without causing damage to other organs or damage to the individual's functioning, then you will always have that kind of recommendation, as in a surgical recommendation for cancers that are solid. Okay, not all cancers are solid, but for a cancer that is solid and you can remove it, you will try to remove it. We talked last week about the fact that some people seem to have cancers that come back even after a surgeon has said that they've received everything. And you want to take care of the disease that might be remaining that you cannot see. And therefore you might use a treatment that can go through the bloodstream, usually, to pick out little cells that still remain. And one of the most effective treatments might be that group of treatments called chemotherapies. And then sometimes you may need to treat remaining microscopic disease by sending beams of radiation to search out those cells. And then there are other kinds of treatments where you can place medicines into the body that say to the immune system, we call these immunotherapies, there are cells that are behaving badly. We need you to modulate how you are working. We need you to strengthen how you're working. And we also need you to, if these cells are present, attack them in certain ways. So there's surgical treatment, there may be chemotherapy treatment, there may be radiation treatment, there may be different kinds of immunotherapy. Now, what I did not say the very, very first time we met, when we were talking about cancer cells, we established that a cancer cell is an abnormal cell that wants to almost live forever, and it wants to make other cells like it, and it's very selfish, and it can build inflammation around it, it can draw other blood vessels to itself, etc. And it figures out a way how not to listen to the body telling it that it should go away and it should disappear and it should close in on itself and die. So most of these chemotherapies or the immunotherapies are trying to say to the cancer cell, look, you need to stop drawing blood vessels to yourself. Or they're trying to say to the cancer cell, you need to stop building inflammation around yourself, because the inflammation acts like a protective barrier. Or they're trying to say to the cancer cell, you were not listening, but we are reactivating the system to help you to listen so that they can close in on themselves and they can die. So from a Christian's perspective, and I know we are specifically on a Christian broadcast, the control programming in cancer cells is very intricate, but the good thing about it is there's wisdom as how you can modify that control system as well so that they can listen. So what I want to say though, knowing the audience that we are speaking to, is that many of the chemotherapy agents are from natural sources that have been modified, or they're chemical sources that have been tweaked to get the cancer cells to listen. And I know lots of persons tend to be confused about chemotherapy, and they tend to think that this form of medicine is extremely dangerous, and sometimes they're afraid of it because of what they've heard about it. So if you want me to talk at any point about what some of the things that can happen to a body when you use chemotherapy and why it can still be advantageous, I'm happy to do so. But I do know that some persons are a little skeptical, but those are the main things. Treatment depends on stage. Treatment depends on the type of cancer, how the cells are behaving, and you can do surgery, you can do chemotherapy, you can do radiation, you can also do immunotherapy. And what I would say is that treatment also depends on age. It depends on what we call comorbidity. So that I'm just gonna use you and I, yeah, since we're here together. Like I can have breast cancer because I have breasts, and Dr. Greene, you have breasts as well. So 1% of men can have breast cancer as well. So you could have a breast cancer. But I might be my age, you might be your age, I might be hypertensive, you might not be, I might be a certain weight, you might not, etc., etc. And if we look at our cells, your cells might be good behaved, mine might not be, etc. So when I hear people say so and so took chemotherapy and I ain't taking it because da 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 da, you don't know exactly what that person had. You don't know the kind of cell. You don't know how that cell was behaving, etc. You don't know why. And then another person will say, "But so and so had breast cancer, and they didn't need to take anything, and they're still alive." They might have had a totally different breast cancer profile that was one of those cells that might not have been so well behaved. So the situation is a little bit more nuanced than we think, and I think that it's good to have a conversation about what exactly is happening with your particular type. Now, because we're on breast cancer, there's a kind of treatment that I want to mention because it's very relevant to breast cancer and prostate cancer especially. There's some breast tumors and some prostate tumors and other kinds of tumors as well that respond to hormones. Now, hormones are chemicals that our bodies produce to do particular functions. So today I got a compliment. Dr. Greene, don't laugh, but somebody said they've been watching the program, and, oh, how pretty I look, and all these kind of things. It was really hilarious, but it was nice, you know. But the point is, I'm a lady, so my voice is slightly higher, my skin might be slightly smoother, etc. than females were different from males because of hormones. So something like a hormone like estrogen. So there are some breast tumors that will grow or respond to estrogen. So part of the treatment for breast cancer might be blocking the estrogen to stop that tumor from growing. There might be another hormone called progesterone that might be causing the tumor to grow, and you might need to block that progesterone. For men, there's some prostate cancer tends to respond to testosterone, as in the cells behave abnormally sometimes on exposure to testosterone. So part of the prostate cancer treatment might be to block testosterone production, etc. So I just wanted to say that yes, there's surgery, yes, there's chemotherapy, yes, there's radiation, but you may also hear doctors talking about using hormones, and that's because there are certain kinds of cancers, the cells respond to hormones, and if you can dampen the hormones or reduce the amount of hormones that they're exposed to, then the person can do well. Yes.
Now, I want to just follow up a bit. I'm mindful of the fact that I can't say we will continue next week, but at the same time,
Yeah.
I do want to be sure that our viewers and listeners are well informed. One of the concerns I have heard a lot of people say is, I don't want anybody cut me.
Yes. Yeah.
Surgery seems scary, and
Yeah.
there is this natural fear. But I think I hear you saying that if the cancer is solid, it may be better just to remove it if you can capture it before you deal with other forms of treatment. Am I correct?
Yeah, for sure. And especially we talked a lot about colorectal cancer. And colorectal cancer is one of those cancers, if you're picking it up early, you can remove the section that is terrible before it gets to spread to other things, and you can achieve cure. Same thing with breast cancer. Now, I'm just going to say that a decision to make surgery, to conduct surgery, is usually like a twofold decision. It's about the the ability of the surgeon to safely remove that area, but it's also about the fitness of the person to do well during the surgery and after. So some people may want a surgery, and the surgeon may say, you want the surgery, but your heart is not strong enough, or something like that. So not everybody that wants a surgery can get a surgery. But if you are being offered a surgery, I would say that, and it's something that you and your family and everybody understands, I would say that it can be extremely beneficial. Yes, surgeries will have, anything in medicine has its side effects or its complications, so to speak. So yes, there's complications associated with surgery, etc. But all of the risks and the benefits are weighed and are discussed. But there are some situations where people have been diagnosed with the cancer, they want to have the surgery, but when all the x-rays and the heart tests and the various things are done, it may come back that they're not fit for the surgery. But if you are fit, you should do it. I would say that you
Okay,
should
and
seriously
I,
consider
I,
it.
I don't want to follow up with your, you did invite me to, so I'll follow up on the side effects and
Sure.
chemotherapy, because lots of people are scared. I don't know whether it is what is being circulated, people hear from one another. And you made a very important point that chemotherapy may affect one person one way, it may affect another way, depending
Absolutely.
on stage, etc.
Yeah.
But if you can generally give us just a broad perspective of what can be expected, what happens, how it works, and why we don't need to be afraid.
Yeah, sure. So I'm gonna just describe very simply. Um, there are different categories of chemotherapy, but I'm just gonna try to make it as simple as I can. So chemotherapy as a medicine can usually be taken in your veins through your bloodstream, or you can take it in a tablet form. Yeah, and the way how it's designed is because it's powerful. It's designed to slow those cells down, those bad cells, and those bad cells. The wicked thing about them, I call them wicked cells. They want to move faster than other cells, and they want to spread and divide faster. So you have to use something that will slow them down quite quickly. And when you are slowing them down, there's the possibility, it doesn't happen in everybody, that other cells that grow fast, or so to speak, will also be slowed down. Okay? So there are some cells in the body that grow and divide faster than other cells. The replacement rate, so say for example, the lining of your mouth, the cells on your tongue, the hair cells, etc. If you saw pictures of me last year, I'm growing out my hair natural, and my natural bit was only like this, but now it's a bit longer. But my nerve cells are not growing at the length of my hair, you know? So because there are different cells that move at different rates, chemotherapy sometimes affects some of the good cells. So some people will find that when they use chemotherapy, that the food might taste a little differently. Yeah, that's because the cells on the tongue may get slowed down in how quickly they are replaced. There are some persons, I know this is the one that the movies always capture, their hair cells slow down. So some people may find that their hair might become thin, or they may lose their hair. And the red cells and white cells in the bone marrow, that's that whole system that can become slowed down as well. But as the chemo, how chemo is dosed, in peaks, so that your body can use it, and then it goes down in troughs, and then it's time to use it again in peaks and troughs, just like how you would use maybe like a Panadol once every 8 hours or so forth. But it's not in hours per se, it's usually in weeks. But the beautiful thing is the body recovers. So those cells on the tongue and so forth, they will recover. The hair cells, they will recover. The bone marrow cells, especially the red cells, they recover. If your doctors think that you are not recovering in that gap period like you should, they'll give medicines to help to boost you. But also one of the things that, especially as a Seventh Adventist physician, what we remind persons is the importance of eating healthily as well, sleeping, resting, and doing all the things that we know you should do just to keep your immune system as good as possible. Now, in Afro-Caribbean hair types, our hair type is very, very variable. So I'm sure if you're like me, your hair does a million and one things, at different points in time. But so some people will find that when their hair grows back, it may grow a little straighter at first before they get the natural coil again, and that's one of the things. And but the tongue cells come back, etc. The other thing that can happen with some persons in a particular kind of chemotherapy that's very common, you might feel like your hands and feet tingling a little bit if the nerve cells are affected, or they may feel like a little numb, but that also corrects itself and it responds very lovely to vitamin B6 and stuff like that. So for all of these things that can happen, your doctors will usually help you. Some people go through chemotherapy and they don't experience anything at all. They don't even feel nauseous, they don't vomit, they don't feel tired. I remember way back when I first started off, I'm not an oncologist, but I started training in oncology, treating persons. This is like early 2000s in the hospital. And I remember a particular gentleman, he would come, he was a cane cutter. He would come in the morning early. I would get there early so that I could sort his stuff out first. And he would go back to work in the fields. And that's his, some people, they're not bothered at all. But I think the thing to do is to know how to plan. If you're having chemotherapy, your doctors will walk you through any medicines they want you to take before to minimize any side effects. They'll also give you things to stop any nausea or vomiting. Some people say, well, I ain't feeling nauseous, I ain't feeling, and I'm not taking it. And then the vomiting might hit and they may have to catch up a little bit. But as far as possible, that day that you have chemo, you go, you rest, you come home, you rest, etc. There are particular diet sheets that you may have, or different diet regimens that the oncologist and the oncology team might put you on. You follow what you're supposed to be eating so that you remain having nutritious food, and nutritious food that is safe and nothing that will make you too nauseous. Those are the main things. And then there's two subtypes that we also encourage persons to drink lots of water and keep their kidneys nice and flush as well. And likewise, also to keep checking your hearing. There's one particular one that can affect some people's hearing. Yeah. Okay, that was a lot of information, but we are obligated as doctors to tell people the risks. Not trying to Shanghai anybody. So you will hear your oncologist walking you through the risk. And anybody that watches American TV, you will know that whenever they mention a drug, they're obligated to list all these side effects, but it doesn't mean that those side effects will happen, but it's an obligation. And those side effects usually do not occur, but it is possible. And you have to let people know about the possibilities. But if you would permit me, I know we have a limited time. I just want to say there are natural things that we know, because I think the war in people's minds is usually about, chemotherapy versus natural. I know many of us have oleander in our gardens. I don't know what you guys call oleander, but it's a beautiful pink or white flower. Nobody ain't eating oleander, because if you eat oleander, you're gonna die. It's poisonous. And we
Yes.
have it in our gardens, but we know how to treat to it. Or we have bougainvillea. We're not gonna prick ourselves with bougainvillea bush, because chances are your finger is gonna turn out. So, and likewise, if you have, moringa and you have kidney failure or something, you're not gonna be boiling moringa flower or boiling moringa leaf like that, because everything has its appropriate dose and its appropriate use. And likewise, sometimes people will tell you, well, go use the moringa, but they won't tell you the side effects. It doesn't mean that it doesn't have side effects and there isn't a particular way to use it. So I would say, have a discussion, don't freeze, listen, make an informed decision, follow the instructions as best as possible. And if you're feeling untoward or side effects that you don't feel comfortable with, keep having a discussion with your doctor. Don't close off the conversations.
Okay, very useful. Now, when we talk about treatment, when we talk about having to do, whether it be surgery, for cancer, that is, or chemotherapy or radiation, one gets the sense that these are very expensive. I don't know if, and for the popular types of cancers that we have, breast cancer, I'm talking about in the Caribbean context, breast cancer, prostate cancer, we spoke about colorectal cancer. How expensive is treatment?
Okay, I'm smiling because I want to take the long answer. I think that treatment is more expensive than prevention, right? But
Yes.
yeah, treatment is more expensive than prevention. And I would rather buy my fruits and vegetables and exercise than have to pay for chemo if I had to, right? That's one way of putting it. But to get down
But,
to like
but,
a dollar
but
amount,
perhaps you need to say that again because I think that's so very important. I think our viewers and listeners need to understand that if the lifestyle is right, the risk reduces. So,
yes,
yeah.
yes, yeah, yeah. No, that's what I tell myself when I'm shopping. When I see some of the prices, I say, boy, do I really want to buy these nuts at this price? But then I say, boy, if I have to put this money into chemo, which one I prefer? So try to buy proper food, try to invest in the health. So the health systems are different across the Caribbean. In Barbados, we are very fortunate in that our first line chemotherapies for most cancers are free. Yeah, if you're Barbadian national. So that's like, say for breast cancer, there's a drug called adriamycin, doxorubicin, those older drugs, cyclophosphamide, etc. And there's some of them that you may have a co-pay with. And if you're in the full private sector, you're talking, in Barbados, you're talking, a few $1,000s per month, which sometimes is beyond the reach of most people. And that's just the drug itself. That's not the blood tests and so forth that go along with it. So yeah, and I would say that some of, like, say for example, if you've done very well for a couple of years, like 7 or 8 years, and then the treatment has reoccurred, some of the newer treatments are far more expensive, and some of the newer chemotherapies are expensive. So I can only speak to the cost in Barbados, and I would say if you were going, first line chemotherapies, private, it can be a few $1,000s for quality care, and we have very good oncologists here, and that do provide quality care. I'm not putting in a plug for anybody, but I do think that all of the oncologists and all doctors would rather that patients not become sick in the first place and have to seek oncology care. A lot of some of the things that we need to do to monitor how a person is doing are not always, some of the other things are not available in the Caribbean. So something called PET scans. We don't have a lot of PET scan capacity in the Caribbean. And people might have to go to Miami and stuff like that. So that's cost of flight, cost of airfare. Well, that's the same thing. US visa cost, accommodation, and that kind of a thing. There are some services now, some concierge services that once your doctor in your island knows that you have a particular condition, they might refer to, Trinidad or Barbados used to be for some things, or they might map you to treatment in Puerto Rico or maybe Miami or something like that. But so there are those concierge services that people can, tap into. But those kinds of things would usually require some level of insurance as well, some kind of health coverage. But you do have patient navigators that can help. But within our health system in Barbados, lots of the first line chemotherapies are covered, and the first line radiation is covered as well. But I cannot speak with authority. There's a paper that we have out in 2019, is it last 2019, when we did the mapping of services, and the service provision in the Caribbean was not what we would have wanted it to be in terms of the number of islands that have access to radiation. A lot of persons in like the leewards, y'all can northern and southern leeward, y'all can maybe go to like Puerto Rico, etc. But it's harder for some persons to find the money and the funds and so forth. So I think we need to do a lot with surgical capacity in most islands is good. Yeah, there are some of the higher, well, I don't say higher, but the more subspecialty surgeries like hepatobiliary surgery, where you're taking out pieces of the liver or the bile system, or people who have the skill set to do complex pancreatic surgeries. We didn't have a lot of that in the past, but there's quite a strong network in Trinidad, and it's quite a building network of hepatobiliary pancreatic persons who are comfortable with pancreatic surgeries in Barbados as well. And I'm sure throughout the other islands, the doctors It might be good for persons to know like the list of surgeons that are available to do the different kinds of surgeries, but it can be more expensive than, when you think about a month of chemo being 7, 8, 9 months of groceries, you know, that's better to probably invest.
I don't want to go into politics at all, but we have something called CARICOM.
Yeah.
Do they have the health dimension to, you just mentioned, for example,
Yeah.
list of surgeons and what care is available where, so that as Caribbean islands and as they collaborate together, one can say, this is a good place for that, that's a good place for that.
Yeah. You make an excellent suggestion there in terms of a treatment map, a map of services. We started something recently. I think the website now, when you go on it, for some reason, we were trying to figure out why some things are blacked out. But for sure, there's a Caribbean Palliative Care Association. There's a Caribbean Association of Oncologists, and then there's same for urologists and same for surgeons as well. For the Caribbean Association of Palliative Care, you can go there and you can click on the particular island that has services, and you can get a number and so forth. I'm not sure of the surgical directories, but at the level of the CARICOM, there's a system in place to help islands to understand what's happening with them. So there's like a registry for, at least that keeps track of how many people have cancers and so forth. But I am not sure if there is a full directory of cancer services across. I think some physicians may know, like we know linear accelerator, you can send patients to Martinique, you can send patients to Trinidad and that kind of a thing. That's a particular really nice form of radiation that is really high tech. It can get to the precise area of the cancer, and you can change the conformation of it every day as the cancer reduces, so that the person gets the least amount of radiation. And in Antigua, y'all have that capacity as well. I think physicians, we know, but maybe the general public doesn't know. And the general public probably needs to know to say, well, hang on a minute, can I go here to get this, and can I go here to get that? So I think that's a good suggestion. But I'm thinking that it doesn't exist in the way that you're asking. It exists in like silos.
Okay. Now, given the challenge with the average person, and given the popularity of cancers and other forms of lifestyle diseases, um, your suggestion would be that people make the sacrifice and do health insurance?
Oh, if that's a good question, but I think that I don't want to be hypocritical. It depends on how much people can put aside with the understanding of the risk and what the risk is for catastrophic loss of their financial stability if they don't have the health insurance, right? If putting aside $50 a month, $100 a month that you may never use, if you cannot see how that may benefit you versus having to hunt around for, say, total treatment, 100,000, 50,000 US. There are people who literally have to make the choice between, am I going to put my child through school, take from their university fund, pay for my car insurance, do whatever, versus treat. So if you know that you're in the financial position where if one of these diseases had to come, it would drain you and it would drain your family, then it may make sense to have health insurance in the event. But I don't I know that determining whether a person will benefit from health insurance is far more, complicated. But these fancy things that the actuaries do to make sure that it makes sense for the company and it makes sense for the patient. But I'm saying, if you know, for example, that you're not in a position to pull from cash, and you're having to make a decision between draining your family, sustaining your family, and your health, then maybe health insurance might be useful. I know. I think according to policy, some of our ministers might be in some relatively fortunate positions. I'm not sure that there's a health system in place for group congregation insurance. I don't even know if that's where you're going.
Well,
But
the reality is, given from my perspective, the frequent appeals for assistance with medical care, I really seriously counsel people to make a sacrifice and get health insurance. Because take, for example, I'm not going to use a popular enough cancer in men, prostate cancer. If a man discovers, and because a lot of men, in spite of all of the education and the push for people to get tested, and some men don't want to, and if a man discovers that he does have prostate cancer at a stage that is serious, when you look at the expenses associated with it, the average person on the street may not be able to say, hey, listen, I'm going to, because a doctor is going to sit you down and he's going to say, here are the options. You can do surgery, you can do chemotherapy, you can do, I mean, again, radiation, whether we're going to insert whatever, or you're going to remove the prostate. All of these are expensive, and the average person does not have and depending on where you live, the surgery may not even be available, the treatment may not even be available there. So when you think about airfare and accommodations, etc., one major illness can run you hundreds and thousands of dollars. And so I think people do need to consider those things.
Yeah.
But let's get back to the discussion on cancer, because there's so much more, and I'm gonna have to select which questions I ask you now in the interest of time.
Sure.
But on our first program, you made a reference to alternative or non-traditional treatment. And just now you mentioned, if a person has something in their yard that somebody may tell them, for example, you hear and you can see, and sometimes on internet, that soursop, I've seen people saying soursop is better than chemotherapy and these kinds of things. So I want to ask you about alternative non-traditional forms of treatment. There's a lot of stuff out there on the internet, and a person may get some advice from a friend to try such and such. How should one relate to alternative treatment?
Right. So I think the thing is that we need to, I want to use another word. I would use the word complementary. I'm going to focus my A here. I would use the word complementary. If there is a trained person who is knowledgeable and is, as far as possible, registered in your island under whichever paramedical council, I think that is the person that you should go to if you're saying that you do not want to use chemotherapy, or if you're wanting to use these treatments alongside chemotherapy. Then your oncologist will definitely need to know, because some things will interact and might change the therapeutics. And I think also to be mindful that some of the medicines that might be prescribed, or some, I don't want to say treatments that may be prescribed, even though you might not use that word, from complementary medicine persons, it doesn't mean that they're side effect free. Okay. And sometimes where I am clinically, I do primary palliative care. So I see persons like closer to sometimes in the most difficult parts of their journey. And so say, for example, something as simple as a tincture, you might go to your complementary person. If that person is not trained and you have, like, say something is wrong with your liver or your pancreas, and the way how your body is controlling blood sugar is not quite right, and you're subject to low blood sugars because of how your liver is not working as well as it should. And I see some people on things that will, can cause their blood sugar to go very low, or can cause them to bleed, or that can cause the just to accelerate the liver failing, or that can cause dehydration. And then you're kind of like, why are you doing this when your liver is working like in the way it is? So let me give you a simple example. If you have liver failure, your liver is very sensitive to what is put in it, and things can become very toxic. So something as simple as cooking cassava, yeah, you might not be able to use cooked cassava, but you may have somebody who's being prescribed something related to cassava that will damage the liver, and there's no communication between the person who is offering this other treatment and the regular doctor. So I think I would have mentioned this maybe in the first part, but if there was the ability to talk I think a lot of persons would be saved a lot of heartache. And also there's a way how God is giving us to understand the way how the body works. So yes, you can look at a microscope and you can see cells. So one of the things that a lot of people say, okay, somebody looked at my cells and they said that there are parasites and there's fungus and I have to stop eating sugar and I have to stop eating bread and I have to da 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 da. And when they tell you all the things that they're on, it's amazing that they're maintaining any kind of weight, because the nutrition profile from some of the other practitioners is too restrictive, not balanced enough, and so forth. And I think fundamentally, without rambling on, I think there needs to be communication. And I think people, if you're going to take advice from somebody, it can't just be your auntie or your cousin or the neighbor next door, those kind of things. It has to be somebody with, substantial knowledge who does not also walk away when you are sick. I think that person is the part that hurts me, where persons, they go and they buy supplements and they buy this leaf and they buy the next leaf and they pay thousands of dollars too. They can pay some high fees too. And when you up a creek, to use that word on your show, that person cannot be found. That burns me. That really annoys me and upsets me, especially when persons have delayed accessing care that could have been beneficial, and then their liver is failing, the tumor is too large to be removed surgically, it's infected, they're bleeding, and that person is nowhere.
Well, let me throw this in too. If I go to a naturopathic physician and the individual says to me, listen, you're being treated for such and such, let's say cancer. I'm going to give you this, I need you to stop taking your medication. When a person says, stop taking your medication, how should I respond to something like that?
Firstly, if a person says they're treating you for breast cancer and they're a natural physician, ask them which kind of breast cancer, ask them what subtype it is, which hormones it's responding to, which hormones they are trying to manipulate. You should probably ask them the extent of the spread, what they're making their decision on, and if your body is strong enough to take the treatment that they are offering. Because God has given us too much knowledge about cancers and how they behave to be just saying this and that and the next. And the thing about it is there are naturopathic practitioners who are trained enough to understand the hormonal types and the blood types and all the various kinds of things. So if you have one of those, that's really good. You can do full integrated medicine with that. But just not any random person can just tell you stop taking the medication, because they will have to if it was me, they will have to convince me that they understand my cancer properly to tell me to stop using something that is potentially to my benefit. So I would have to make sure that I am walking away with full knowledge that they know what they're doing. If
But
that makes
another question, and I'm kind of switching a little bit because I mean this is our last program on this discussion on cancer. You're into palliative care, quite an expert in that area. In spite of all of the treatment options that are available and the scientific intervention, some persons still do not respond, and we still have people dying from cancer. And they're individuals who were told so frequently that, listen, this is too far gone, we can't do anything. Can you talk to us a little bit about palliative care and how that works, especially in you may want to say with other diseases, but because we're talking about cancer, how does that work?
Sure. Okay, so firstly, want to say that palliative care is not just applicable to persons with cancer, it's applicable broadly. It's an approach to care. Okay, it's not a set formula, it's an approach to care, and the emphasis is on holistic care. Okay, and it's holistic care that's set to improve the quality of life of a patient and the patient and their family. So the clientele is dual. So patient, their families, you're trying to improve the quality of life of that patient through holistic care. Now, the beautiful thing about palliative care, you can use palliative care and benefit from palliative care even in the early stages of a disease, right? Which is when we talk about even when cure is still being sought. It doesn't have to be when there's no possibility of cure, but it comes into its own, and it's the dominant form of care when the curative forms are not as effective. But we find that when patients can access that holistic approach from early on, they do really, 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 really well. And that is something that we want people to grasp. But many health systems can't afford to start that integrated palliative care early, so they start it very late. When it is late stage, the emphasis is still holistic. So we're looking at what's happening with that person emotionally, what's happening with them spiritually, what's happening with them physically. So if there's any physical symptom like pain or nausea or vomiting or bed sores or diarrhea or constipation, any symptom like that that needs to be managed, we try to manage that. But we are also interested in making sure that that person understands that they're valuable and that nobody has given up on them and they cast them away. There's always something that can be done, even if cure is not possible. And even if the person is deteriorating, even if it's as simple as, making sure that their room is nice and cool and there's a fan and it's quiet and they're pain free or whatever, there's always something to be done, because we never want a person to pass away in an undignified way or in a way that is uncomfortable. And we certainly don't want families going through that. So even like down to like what happens to your hair, what happens to your skin, making sure that your teeth are brushed, that your mouth is taken care of, that your minimal bed sores or that kind of thing, all of that is what's involved in palliative care. And then finally, should the patient pass away, to make sure that the family understands what's happening, when it's happening, that the family is not alone. If a person is passing away, to make sure that when they do pass away, especially if they pass away at home, everything is done with dignity according to law and everything, and that the family then gets the support in the bereavement period. And that is a lot of what palliative care does. In different islands, it looks like different things. So for anybody listening to us this afternoon from Trinidad, they have their regional health authorities and they have palliative care teams. They have San Fernando General has a palliative care, I think, outpatient clinic. They have a couple hospices. In Barbados, we don't have any standalone hospices, but we do have, and there's a difference between hospice care, which is usually the American definition, is the very last 6 months of life, when they believe that no cure is possible and you pull off all life-sustaining measures, those active life-sustaining measures. You agree not to do that, and that's partly because of how their health
But
system is developed.
in fact, I was just going to ask you whether palliative
Oh,
care is the same as hospice care, and if no, then what's the difference? So
yeah,
you're beginning to
yeah.
understand.
So they're not the same. They're not the same. But palliative care can involve hospice care. But hospice is usually when a person is in the last 6 months of life. And so palliation is to cloak and to cover any symptom. Usually hospice is usually when you're certain that that person is in that active dying phase. I should say end of life phase and going into the active dying phase. And usually especially in the American health system, there are certain rules and regulations about what you agree to when you access hospice care. But to say that in Barbados, what has been built is a system of at-home palliative care services. So there's general practitioners that go to persons' homes and like receive referrals from the hospital and etc. And they can go and help families in the home setting. There are also some nursing homes where they can provide that service for families when they're nearing the end of life. There is training that is available for nurses, training that is available for family members, because family members have a real active part to play in providing palliative care in the home setting, and clergy and so forth. So palliative care is quite involved. And I would say, Dr. Greene, because I see you looking at the clock, I know we're running out of time. The second Saturday in October is World Hospice and Palliative Care Day. So I can come back in October.
Okay, I will write that down.
And
I
do
will write that
a
down.
proper program of palliative care, because it's
Yes,
such an
certainly.
important thing. It's such an important thing, and it's just not for cancer patients. It's really about improving people's quality of life. It's about holistic care, making sure that if you really are in that phase where life is very difficult and very challenging, and if it is that cure is not possible, that you're not feeling like you're cast off and your family is not sure what to do. And we don't want people suffering and dying and spending those last precious moments in uncomfortable ways. And that's what palliative care seeks to address and to stop.
Well, I'm glad you mentioned that you can come back on the second Sabbath in October. I'll make a note of that. Yes, for
God
sure.
willing, God spare life.
Yes. Yeah. Now, before you go, I must ask you this. This may be our final question, but you know, we have spent the last 4 weeks talking about the Christian and cancer. We have learned a great deal, and we really do appreciate the quality information that you have shared. But before you go, from your perspective, how should a Christian relate to cancer? And should we as Christians be more responsible? And is it reasonable that we should expect fewer incidences of lifestyle cancers among Christians? I know that some cancers are not related to lifestyle, but many are. And I know I'm asking quite a bit here, but
Yeah,
can you respond to that?
sure. So firstly, I would say that one, from a Christian perspective, that life is full of challenges, and sometimes there may be the mistake that a challenge like an illness like cancer is a curse, or that you are have somehow, being cast off by God or something like that. I think a lot of people struggle with that. And I would first want to say that in every situation, God is able, He is with you, and He knows what is best. And by trusting and abiding with Him and the knowledge and the wisdom that He's given other people, you can navigate very, very difficult situations, even down to the very end. And I think in our world church, we recently had the beautiful example of what can happen when a person is challenged and maintains faith through the life of Dr. Heather Dawn. But the reality is that there are so many things that we can be exposed to that can cause a cell to behave badly, that it is almost our responsibility to do our best to keep our bodies as strong as we can, because there are so many other things that could go wrong. So if you can get to bed early, get to bed early. If you can know the carcinogens that us as doctors know, alcohol, tobacco, red meat, processed meats, the sedentary lifestyle, the obesity, the central obesity, especially, if you can do your best to minimize those things and maintain your trust even when difficult circumstances happen, I think that that is our responsibility. And further, I think that if someone should have a diagnosis of cancer, we as Christians should not be stigmatizing, because I know in many islands it still is very stigmatizing. I ain't going there, that person had the breast cut off, da 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 da. We should as Christians, I think that we should know not to be that superstitious, and that we should open our arms of love and to help as best as possible. But there are things that we can do to reduce risk. So if it's perhaps early detection, pap smears, mammograms, PSAs, the fecal occult blood test that we talked about, we covered so many things in the past 4 weeks. As much as you can do to keep your body healthy and to encourage the people around you to be healthy and to detect things early, we should. And then if we are faced with a diagnosis, to be as responsible as we can be in getting information from the right persons to make the right decisions, I think that we should. And I think we should not vilify people who choose to use chemotherapy or anything like that and say they have a lack of faith. And for those Seventh-day Adventists, Ellen White used radiation way back when it first started. She was on board. So I think that we need to know our medical history for ourselves as well.
Well, Dr. Graves, I want to just express profound appreciation for the wealth of information that you have shared with us over the last 4 weeks. I want to say to the listeners, those, whether you're on Second Advent Radio or you're listening on YouTube, the information, all the programs on YouTube, you can always go back, you can share with your friends, you could let them know that, this series on cancer is there, because this is very, very valuable information. We are grateful. We wish you God's blessings. We
Thank
are
you.
so happy that you were able to make the sacrifice. I know that some of our viewers may not know, but on some occasions you have had to cancel programs and so on to make yourself available. So we really, really do appreciate this. And may God bless you, and may And please say a special thank you to your family for me, because
Oh,
sometimes you had to come away from lunch. I have not had lunch yet because
right,
of the program of the day,
right.
but we really do appreciate it.
You're
To
most welcome.
Certainly.
Most welcome.
And to our viewers, we will be back next week. We're going to be talking about something else exciting and important. I suspect that next week we want to look at dental health. And the dentist went ahead and said to me, some people don't even know that there could be a link between dental health and cancer. So that's interesting.
Great.
Coming up next week.
Yes, to
Until
talk about
then,
lymph cavity is
may God
amazing.
bless you all.
You're welcome.
Enjoy the rest of your day.
Thank